Hey guys, welcome back to the Foam Frat podcast. Happy New Year, the first
Happy New
Foam
Year.
Frat podcast of January. And we kicked it off with Dr. Banerjee. Dr. Banerjee is actually one of our secondary medical directors now because with the CE processing and the stuff we're doing in Florida, we had to have a medical director in Florida, plus really a big fan of Banerjee studies and cardiac arrest, specifically the pediatric cardiac arrest one we talk about in this podcast. So we're happy to have him on board, and it was fun to start it off with a podcast. So this podcast, or I should say this interview that I did with him, was part of an ongoing interview in the new logistics of pediatric arrest talk that I just put in studio. So we go over the mindset, the chunking of, all right, when we first get there, we got to do this and then this, the humeral head IO, how to place that. It's all the logistics of running a pediatric arrest. If you haven't checked that out, it's in the pediatric section of studio. And then we break away and we go to Banerjee and we talk about some stuff. If you watched that class already and you enjoyed listening to Banerjee, this is like the unedited version of everything we talked about. It was a much longer conversation, and we really hit on some cool topics. So Sam, I sent you just the raw audio file and you were listening to it. What type of questions popped up in your head?
I don't want to get too much into the clinical topics that you guys talk about. I mean, it was a lot about like simplifying the approach to pediatric arrest, and he talks about some different statistics in there and where they started and where they went after that. But the thing that stuck out to me, or that I kept thinking about, and this is kind of maybe a side point, but this is just what it made me think about, was like EMS identity and how that crew views themselves when they show up on a cardiac arrest, or really for any type of arrest, if we can zoom in on that topic. And here goes a sports analogy for two guys who
big sports buff,
the real sports buffs over here. But I understand that there's this thing called special teams, and special teams, if you have like football, which is not soccer for those of you who are listening in other places, but they have these special teams that when a certain situation arises, they take these people who have kind of done these specialized drills and they put them out on the team, and they say like, okay, you guys have run this together. You guys are the teammates that are gonna, are cohesive, and you guys figure this out. You've run through this a number of times. And I think that there's a little bit of a lack of identity there with EMS as far as like being a special team for something like pediatric cardiac arrest, where maybe EMS assumes, and I can't speak for everybody, but I think there are definitely places out there where they assume that we're just EMS. We need to get this patient to the hospital because they're the experts and they're going to run this. And it was interesting to hear Dr. Banerjee really not agree with that. And there's this kind of thought that once we get there, they're going to have the physician. Anesthesia is going to come down. You got a boatload of nurses and respiratory therapists and all this kind of stuff. But when you observe those situations and you watch how the hospital runs it, and it's not always this cohesive thing. And sometimes they're just as confused or just as flustered as EMS is. Plus you throw in there the transfer of care, which for any complicated patient is not easy. And so to me, it just kept reminding me of like, how does EMS view itself? Does it view itself as a specialized team who has this very small circle of control, very good closed loop communication? They've drilled on this a bunch of times. They have these things figured out, and they view themselves as like the experts in this type of out of hospital cardiac arrest, where they can get these staples of care done that they know they absolutely should do, and they've drilled on it to get these things done in a timely manner. Or they just kind of kicking the can down the road and saying, our identity as an EMS agency is to transport this child, and then the experts will take over once we get to the hospital. Not saying that one person is more of an expert than another, but I think that in this instance, it comes down a little bit more to how do you view your approach to the logistics, because just getting down some of those basic things that that you should do, if you cement that in your brain that like, we're going to do this before we go or do anything else, establishing those basic like staples of care is what apparently makes a huge difference.
Yeah. and I don't want to get into it too much, but in this episode, he talks about how they're applying the Lucas at even an earlier age than we originally thought we could apply the Lucas, and it's working. The timing of epinephrine, we got really good evidence for that in like the asystolic PEA arrest in kids, supraglottic airways, all of that is included. So make sure you guys listen to the end of this because a lot of the little clusters are towards the end. And we want to thank Dr. Banerjee for coming on.
Yeah.
All right, let's roll it.
Let's roll it.
So let's start off with, what do people like generally do? Like, it's not like they're just picking them up, throwing them in the ambulance and driving, right? Or are they? I mean, what were you guys doing before you implemented all this?
Well, I think before we were no different than everybody else. I think pediatric arrest is something scary. Don't do it very often. We get 30, which seems a lot for most counties. So it's a lot easier to look foolish behind closed doors than it is to look foolish in front of closed doors. So I think most people would pick the child up, go in the back of the ambulance, drive real fast, and kind of look through the protocol book and kind of do a Hail Mary and see what happened. There was no structure. There was no process. It was just, I did my PALS course. I did it for 2 years. I should be certified now. I actually have to know what I'm doing. And I think that's kind of what happens. And I think it happens everywhere. It's just the easiest thing to do is you do your PALS course, you get done with the class, and hopefully nothing happens. But if it does, how prepared are you if you don't train on it?
Yeah, absolutely. And in my experience, a lot of times the family will come running out with the child, right? Or they want to meet you in the driveway. And in those circumstances, you can feel like the pressure of, hey, we need to, let's just get going. But I think it's important to have that conversation or have a culture within your department of, hey, even if they come running out there with the child, yeah, maybe we'll resuscitate them in the back of the ambulance, but we're not moving right away. We got certain things that we need to get done before we start that trek to the hospital. So you guys identified that. You went from 5.3% ROSC rate between 2012 and 2013, no survival, I believe, at all during that time. And then you guys did some training, you went over some stuff. And between 2014 and 2015, the ROSC jumped up to 30.4, and then 13 out of the 56 or 23.2% survived with good neurological outcomes. So what did you do? That's the $1 million question. What did you guys change?
Well, I think we changed everything because, no matter what we did, we followed what everybody else did, and no fault to everybody else. No matter what we did, it couldn't get worse than 0% survival. So everyone was doing the tape, everyone's doing the PALS course, but I don't know if that was sinking in. So I think simplicity is the best thing you can do for anybody in a stressful situation. Kind of learned about the hand-heavy system. That seemed to be a pretty easy thing to learn because most everybody has a hand, especially in EMS, and then you can kind of use that hand to guide what you're trying to do. And so we took math away from them. We basically said, look, if you're 1, you're 10 kilograms, 2, and just use your hand to guide you based on weight and age. So we kind of knew how much they were going to weigh. We kind of knew what they were going to need. So you already have that kind of in your mind. Kind of like when you do an adult, you don't worry about, hey, I'm going to give an epi, I'm going to give VTAC, I'm going to give defibrillation. I know the doses I'm going to do. So it's just second nature. Well, pediatrics is not. So how do you change that and make it easy? So when you simplify it, things become easier to do, easier to implement, and much better outcomes. So we said, well, instead of running them back to the ambulance, you wouldn't do it with an adult who's like a 70-year-old guy. You would like pick him up off the sofa, put him on the stretcher, kind of do mediocre at best compressions, put him in the ambulance and drive real fast. So why would you do it for a kid? So yes, if they run out to you with hands with a child, take the child. We kind of assign somebody to take care of that mother, that father, kind of explain what we're doing. We're not going to go to the hospital right now because everyone thinks the hospital is where you're going to live. Usually if we don't get the ROSC back, the child's going to die. Very, 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 very. If I had enough varies, I'd add some more. That it's unlikely that they would survive if they got to the hospital. They don't do this every day. They're not very good at it. I've seen my colleagues. It's just not something they're used to on a daily basis. And maybe at a tertiary center that's different, but at a local community hospital, when you have an ER physician who doesn't deal with this on a daily basis, they're just as confused as the paramedics are. So how do we control the scene? How do you limit the distractions? Well, you need compression, so let's do that in the back of the ambulance. We know you need an airway. Let's get that done immediately. Let's also start getting an IV or an IO, start compressions. And then once we get that, once we've eliminated all the peripheral noise and we focused on what matters, now we can get this child to get a pulse back, control the airway, and find a better way to get resuscitation. And so just by staying on scene, I think people go, well, okay, I'm not going anywhere, so I need to know what I'm doing. So you need to start compressions. We do bag valve mask for less than 5 minutes. And then they do any eye gel or definitive airway intubation if they're comfortable with it. And they just start the hand-heavy / PALS guidelines that they're used to on scene.
Yeah, I was looking at your initial defibrillation dose was 4 joules per kilo. And if you look at like the AHA typically recommends starting at 2, then going to 4, all the way up to 10 or the max adult dose. What made you guys start at 4? Just trying to give it your best shot the first time?
Well, it's kind of like if you read the Stryker studies too. Stryker had if you're in VFib, they say go to 200, then 300, then 360. It kind of made no sense for me to play with that. Why don't you just go straight to 360? Because say you'll get 90% of them at 200. You just want to touch the heart. If it's 300, you'll get 95%, but you'll probably get everybody at 360. So why do we play this game? Just go right, max out. That's if they fail. What the first thing you do is you double the dose. Right. So you can't fail much more than being dead. So why don't we just try to do max out at the defibrillation joules too?
Yeah, that totally makes sense. I was looking at the new guidelines, the 2020 PALS guidelines when they came out, and they even mentioned in there that the 4 joules had a better rate of ROS. So it makes total sense to do that. Now, in your study, the majority of your arrests presented with PEA or asystole, correct?
Correct. And approximately, if you look at the ratio, it's about 80% PEA. And I think that kind of correlates with the national average. 80% or plus are PEA, and then less than 20% are VFib. So another thing is, not all arrests are the same. Right. You treat a VFib arrest completely different than you would a PEA arrest. So what I kind of focused in on, well, knowing that 82% of these arrests are PEA, why don't we hit every possible treatment for PEA on scene? And that's why we hit all the H's and T's while they're in that 10 minutes. So we try to reverse any possible bad outcome as aggressively as we can, not trying to be intellectual, not trying to be thoughtful, kind of going, well, these are the potential causes. Let me hit every potential cause and let me see if I can get a good outcome from it.
Yeah, and the literature for epi in pediatric arrest is actually pretty good compared to like what you see for adults. And there's actually like a time frame where you want to get it on as soon as possible. I was looking at an in-hospital study where they were able to get it on within like a minute, probably because they already have access. And then I was looking at another study out of hospital arrest, and they found like the average time was like greater than 10 minutes. And I was looking at the PowerPoint you sent me, and it looked like you guys went from like average time to epi admin with ROSC from 26 minutes down to 5.6 minutes. So what did you guys do to improve that? Just really stress, hey, if this is PEA asystole, get that epi on as soon as possible?
Well, that's part of it. But the other thing is, when we call through dispatch, if we knew how old they were, we knew what dose of medicine they were going to need. So we already had it pre-drawn up prior to arrival. So there wasn't any fumbling on scene. Okay, how old are you now? You're 3, so that means you're 15 kilograms, and I got to drop them. So you're driving, you have about a 10-minute drive or so to where you're going. You have everything drawn up. So as soon as you get there, no IV, boom, you get the IO, you push the meds, start compressions. So you've eliminated dead time, and that was the goal of The hands heavy helped with that because we knew we didn't care how much they weighed. We knew we'd give them based on ideal body weight. And that's how we approach the patients.
And when you have a crew responding, I mean, you have an ambulance and then you likely have an engine crew too?
And police.
And police. Okay.
And you look at a lot of dispatch protocols, they are not necessarily, they're like beta, I guess priority. And we kind of made everything or it was alpha or beta priority. It's basically, so it means you don't have everybody go, but we changed that and we had everybody go. Police, fire, EMS, everybody went for a pediatric arrest. So there was a higher sense of urgency for the system to approach the kids as well.
So what do the logistics look like? Like who's drawing up the epi? Is that the ambulance crew? One person's in the back setting stuff up and the other person's driving, or how do the logistics of that look?
Well, the paramedic in the back of the ambulance will be drawing up. If there's a fire engine going ALS to the response, they're going to be drawing it up. So it's basically whoever the paramedic is nearest on scene, everybody kind of has it drawn up. Now that can lead to some increased waste, but I'll take our numbers with the increased waste versus saving our numbers and saving epinephrine kind of thing. So,
yeah, no, absolutely. That makes sense. And then were you guys trying an IV or were you just going straight to an IO?
Well, my EMS chief at the time was kind of mad at me because, IOs are expensive and IVs are cheaper. I said, all right, well, how about this? You get one attempt at an IV. And if it doesn't work, you go straight to IO. And, as paramedics do, I can't get the IV. Boom, I'll get an IO. And here we are.
Just put a Band-Aid on the arm. Oh, we tried.
Yeah, I tried.
Yeah. And then was that the distal femur that you were using?
Actually, initially it wasn't. Initially, it was the tibia, which is kind of everything. When we started this about 2014, 2015, information didn't really come out about the distal femur. That kind of came out in 2021, but we have evolved to that since that literature came out.
And then when you guys, your airway, was that initially just BVM compressions and then you put an i-gel in as soon as possible? Or what did the airway management look like?
So it was BVM for less than 5 minutes. The problem with BVM, it's great temporarily, but what happens is the air goes to the lungs and the stomach. So now as the stomach goes up, you decrease thoracic airway space. So you increase intrathoracic pressure, which is going to decrease coronary filling, which defeats the whole purpose of what you're trying to do. So we minimize the bag valve mass time, less than 5 minutes, go directly to, if you can do an intubation, great. If you can't, you have the i-gel, but there's also a gastric tube with the i-gel, which will help decompress the stomach. So we use that if that's not possible.
And at what point, let's say you're working this, you're not getting a pulse back, maybe you're shocking. At what point would you start to transfer? You would start to transport to the hospital.
We stay on scene for at least 10 minutes or until ROSC.
Gotcha. And then when you're transporting, you're going to just the local hospital. Do they have the capabilities of doing ECMO, or what does that look like? Is it just basically getting to a hospital so you're not calling a child's arrest at the house?
So yes. Now, if they're unstable, we take them to the nearest facility. But ideally, if we can get anything back, we'll take them to the pediatric center, pediatric resuscitation center, which for us is Arnold Palmer Hospital. And they will fly, the crews fly there, we drive there. It's probably like almost a 45-minute to hour drive. So our crews have to be really good. If we get lucky, we'll get the flight crew to take us there. ECMO kind of came into effect probably around 2022, 2021. With COVID, kind of everything kind of shut down. But I think now it's kind of available. I think Advent has it. Arnold Palmer has it. I think Tampa General has it. So it is available, but the criteria we used to make it simpler for the paramedics was if you're bagging them and then basically water's coming out, they're drowning kind of individual, that would be someone you would be a candidate for ECMO.
Interesting. And then you mentioned the H's and T's and how you just try to reverse them all right there. And I think what I typically see is when, you're working the arrest, you're getting to a point to where there's kind of like a flow that's going, you have all your major interventions done and people are like, all right, let's go through our H's and T's. It seems like everybody goes, hey, you guys want to try bicarb. And if you look at the AHA, they no longer recommend the routine use of sodium bicarbonate in arrest. So I'm curious, what does your H's and T's look like? I mean, are you giving dextrose, Narcan, bicarb, and just knocking them all out? Or are you guys actually, I'm just going to stop there because I want to know what's your thought process on that?
Well, I take a lot of what AHA says with a huge grain of salt, and use it when it's convenient for me and ignore it when I don't think I agree with it. I guess me and medical director for San Antonio is probably similar in our thought process, in that we kind of use it for a basis, but ultimately, you don't know if the kid is hyperkalemic. You don't know what medicine they took. A bicarb isn't just for acidosis, right? It can be a buffer for TCA ingestion. It could be a buffer for hyperkalemia. So we don't know what the cause of that arrest, adult or pediatrics, is. Whether they take medications, were they drowning on the bottom of the pool? Did they go into rhabdomyolysis from a crush injury? We don't know. So why do we try to be intellectual at that moment in time and decide, well, I don't think this person's a good candidate for bicarb? It doesn't hurt. And I guess the AHA studies can say either way, but I mean, our numbers are much better than anything in AHA. So I'm not really concerned.
Yeah. So that's what I'm curious. So do you guys routinely give bicarb after 10 minutes of the arrest?
Yes. We actually give it during the arrest. We basically do that within the first couple of rounds. So we don't really even wait for 10 minutes. We do the epi, we do the compressions. And then, if you need calcium's available, bicarb's available. We do the dextrose, the AccuCheck is low, 20 per cc fluid bolus of saline. We also have they're all intubated. So you've got or have an eye gel. So they're all getting oxygen. So we're hitting almost 9 of the 12 H's and T's right off the bat.
Gotcha. Interesting. Well, Dr. Banerjee, thank you so much for coming on and talking with us. You guys, your numbers look great, and we're interested to see, what you guys have next. Is there anything, any studies you got going now, or anything we can be on the watch for?
Well, we did publish something about a year after that, and I sent you that on the one of the slides I sent you. Basically, it showed that for every minute delay on scene lowers the chance of ROS by 5%. That's another a deep dive we had into that study as well. We're also using the Lucas device for children up to the age of 7 or higher now. If they fit, and a lot of the 7-year-olds now don't look like 7-year-olds, but if they fit with the chest compression device, they get it. We're also in the process of getting 50 Eligard's, which is the heads-up CPR device. Yeah. And we're going to use that in children as well as adults. We'll be the first study doing adults and pediatrics on the Eligard. So that's something else to look forward to.
What was what are you doing on scene to see if they would fit the Lucas? Is there a certain guideline you give your team to look at?
Well, Stryker has a little thing they have based on centimeters circumference of the chest. And it kind of led to a 7-year-old could be the cutoff, 7 to 9 years old could be the cutoff on the diameter. But if they look like an adult, and physiologically after the age of 9, I don't think kids really vary that much from adults. So if they fit and the device will work on them, we said, go ahead, use it. So it's probably 7 or higher will be more of a guesstimate use for it. And that's how that we kind of gauge it that way.
Awesome, man. Well, thank you so much for coming on, and we look forward to seeing what you got going on next.
Sounds great. Talk to you later. Thanks.